Demi Radeva, and this is the Akros Advantage. And today we're unpacking recent payer earnings calls. They have highlighted margin recovery in Medicare Advantage and continued strain in Medicaid, often alongside references to portfolio discipline and improved operating performance. But what does that actually mean from a modeling and contracting perspective? I'm joined here by Rachael Jones, CEO of Syntax Health, now part of Lightbeam. And today we're unpacking how margin recovery actually happens, how value-based contracts shape financial outcomes, and where AI meaningfully contributes versus where reimbursement structure maybe remains as the binding constraint. Rachael, I'd love to hear more about you and your background and how you got to be CEO.
Yeah, well, thanks for having me, number one. I'm excited about this and excited about this topic. I know it may not sound exciting, but this is my life's work, so I'm excited to talk about it any chance I get. As you said, I'm Rachael Jones, CEO of Syntax Health, a division of Lightbeam. That's a brand new thing as of December.
Congratulations.
Yes, thank you. Our company was acquired, and it's been an incredible journey to get to this point. I spent about 25 years in healthcare, and I've had a pretty unique career where half of my career has been deep in the belly of health plans and health systems. I actually started my career at a hospital system and then went pretty quickly to the dark side, as they say, to health plans, and spent, a good chunk of the last 25 years in health plan leadership roles at places like Anthem, now Elevance, and Health First, and the other half of my career in tech companies. So I had this unique perspective of building deep in tech and product, as well as operationalizing that tech in a health plan.
You're
right?
a VC's dream.
I don't know. I don't know about that. But a couple of years ago, I had the opportunity to start Syntax through a relationship with Redesign Health, a venture company, venture studio. And it was one of those things where I was not looking to be a founder, but I knew this problem space so well. When you talk about margin recovery, you talk about partnership with providers and payers. In value-based care, there's so much friction and so much opportunity for efficiency and automation. And so when the opportunity came to start Syntax, a first of its kind solution that would be a platform for automating the entire value-based care life cycle, it seemed like a daunting challenge. And why not, right? If why not you, why not now moment. And I enlisted my co-founder, who's our actuary, Emily Walker, our chief analytics officer, and her and I created this company 3 years ago. And we have been really excited to offer something unique and different to the market. And Lightbeam saw the value in that and snatched us up in December. So here we are.
Wonderful.
Yeah.
Well, let's ground ourselves in the current state of value-based care.
Yeah.
Can you give me some kind of stats or where are we at? Because I hear numbers across the whole spectrum. Yeah.
Well, I'll start with the good news.
Okay, great.
So the good news, if you've been following HCP LAN, which is Healthcare Payment and Learning and Action Network, is sort of the think tank, sort of policy holders on tracking value-based care adoption. And I'll say the word value-based care is one of those things that mean many things. It's loaded. Part of the reason we called our company Syntax was the language of value-based care. It's so confusing and complex.
So many acronyms.
Yes, it's alphabet soup. And so, if you track the HCP LAN, another alphabet for you, they've been tracking over the last 20 years growth in value-based care and adoption. And if you look at the most recent one, which I think came out a few months ago, that looked at 2024 data, we finally eclipsed where the majority of reimbursement in this country is flowing through a value-based care model, right? So high level, about 60% and growing. Every dollar of healthcare spend is tied to some alternative payment model.
And is that, can I ask?
Well,
go ahead.
Right? Because that's the big umbrella good news. If you dig low in there and you start to actually parse that out, though, you see that the majority of that 62% is still quality-based only. It's still P for P, quality incentive, quality bonus, nothing wrong with that. But true value-based care, from our perspective, those of us who really do this and are passionate about this work, it's the equation of cost, quality, and experience, right? It's the triple A.
Yeah.
And when you look at those programs that are really looking at accountability, either shared risk, upside, downside risk, capitation, that number gets a lot smaller. Really smaller. And I think that's really where you see a lot of this sort of intersection of margin opportunity and profitability with value-based care intersect, because when you talk about true accountability, we're still not there yet as an industry.
Oh, wow. Well, and I wanted to dig into, do we have any visibility into how Medicare versus
Yes.
Medicaid versus
Yes.
commercial are
Yes,
doing?
we do.
Okay.
We do. And so that same study looks
Yeah.
at lines of business
Okay.
adoption as well as overall adoption. Medicare Advantage
Hmm.
continues to be the star.
Okay.
Now, I'm a little bit nervous because if you've been watching the news, there's been this sort of bottom falling out of Medicare
Yes.
Advantage lately. A lot of
Yes.
plans are leaving because of those margin compression issues, and therefore members are having to find places to go, and they
Yeah.
may not have opportunities in their local markets. So I'm a little nervous about how that's going to unfold. But for the longest time, Medicare Advantage by design has been leading the charge in value-based
Values.
care adoption because so many of those plans, stars, right?
Mhm.
Huge value-based care, quality proponent in the STARS program. And the overall incentive structure was aligned with Medicare Advantage, right? Choice, access, cost management, et cetera. Medicaid, however, is kind of emerging as this like dark horse that I'm really excited to watch, right? Like, especially the clients that we serve at Syntax, a lot of them are community health centers.
Mhm.
And a lot of them rely on Medicaid PPS rates, right?
Yeah.
And they have been sort of left to the sidelines of value-based care, but now states are starting to create mandates for payers to have providers in their sort of shared savings and value-based care programs. And so now community health centers, FQHCs, rural clinics get to be a part of that and get to have those opportunities for incentives, which is so exciting because they're the ones doing that boots on the ground, patient care, primary care focused work, which is so perfect for value-based care, right? So
Yeah.
that's great to see. Commercial. I have a sweet spot for commercial because that's where I learned about risk analytics, especially at Anthem, where I had the opportunity to manage that program. We started one of the nation's first total cost of care programs back in the early aughts, and we grew that program from one pilot in New York to nationwide. So I've got a special place in my heart for commercial. Commercial is so tricky
Yeah.
because there's no one size fits all. It's very employer driven still. And it is very local still, and their standardization continues to be an issue as what good looks like. But I do think you see a desire, especially from large employers, to have some sort of incentive-based program, to have providers have skin in the game, to see better outcomes from what they're paying their healthcare dollar for. And those outcomes look like improved patient engagement, improved quality of care, lower costs, lower spend on high-cost specialties. So I haven't given up hope for commercial yet, but it's spotty.
I love to. Thank you so much for
Yeah.
that amazing just depth and overview. I'd love to unpack something you said earlier, which is stars inequality and then value-based care.
Yeah.
And how are they aligned? How are they different? And how do we get to true value-based care?
Well, so I want to start with the end in mind.
Okay.
So value-based care is simply, right, the dollar I'm paying for healthcare expenditures is generating an outcome that is positive for the patient, the provider, and the payer, right? The payer is CMS or a private commercial payer. And that just simply means if you need care, it's appropriate, it's the right care for you, it's not wasteful, and you actually get better.
Yeah.
And then we're also thinking about and being proactive in preventative care and saying, how can we look at who you are and know who you are, right? I'm a Black woman in my 40s, right? What risk prevalence do I have? Heart disease, high blood pressure. How can I make sure that I'm on track to make sure that I am paying attention to those things that could impact my care, right? So that is truly the value-based equation. So if anyone's talking about value-based care, you aren't talking about quality, cost, and engagement and satisfaction and risk, you're not talking about value-based care. You're talking about something else. So if we got that sort of understood, then all of these different programs, STARS, HEDIS, quality, all of these different measurements and benchmarks are just ways to say, am I delivering value? And I think that's good. The dark side of that or the downside of that is that we have made it really hard for providers to figure out what is actually a good thing, right? And if you're a provider that has commercial, Medicaid, and Medicare Advantage members or patients, right? There go members, patients. You have 15 different dashboards that measure quality.
Yeah.
And I know HCP land has been driving for this, right? And there's lots of organizations driving for more standardization. I think that's our biggest opportunity. If we want to address burnout, if we want to address physician churn, if we want to address, really getting patients and physicians to be excited about preventative care and truly thinking about the long-term picture, we've got to create some standardization and homogeneity in this quality space and move away from some of these process-based measures to true outcome-based measures. Did my costs improve? Did you capture the disease before it became, a negative
Stage
thing?
3 or
Right.
4. Yeah.
Did you, if I got a surgery, was it the right surgery? Right? Do I have the right care post, pre-op, and post-op? Did I go back to the hospital because I had discharged too early? Like all these things are knowable in the data, and I would love to see us as an industry adopt those specific set of measures that truly track did the outcomes improve versus a lot of process and things you could easily grab from a chart.
Did this just checking the box?
Checking the box. And that's where you get so much people sort of saying, oh, value-based is a myth because they're just checking the box. It's not real.
So how much of this can be addressed by AI, and what are still things that need to be
I took notes on this one.
I love it. I love it. You've done the homework.
Yeah.
What are the definitions, or like you said, outcomes versus process type measures that we still need to fix before we add AI on top of it? Because when you're fixing a broken process, what are you really doing?
Yeah, you're just lipstick on a pig.
Love that.
So I think being here at Vive, you can't escape AI. And I do believe that there is so much value in artificial intelligence. And there's also so much that's not new. We've been doing AI and analytics for a long time. Large language models, predictive models are not a new thing, right? What's new is the sort of generative aspect of AI to help you create meaning from what you're seeing.
Yeah.
And that's exciting. So you think about areas where that applies, right? How do I look at a population of members and be able to look at markers earlier about their prevailing risk, right? So I already have predictive models. Now I want to have prescriptive models. Now I want to say, hey, based on the patterns I've seen in all these thousands and millions of patients, this particular member fits this profile.
Okay.
We should probably look at that, right? Or maybe if you think about sort of, if I'm a small provider group or a rural health clinic and I've got to make 10 phone calls today, who do I call? Based on, again, the use of AI, can I prioritize that outreach and know where am I best likely to get that member in and who needs to come in now versus who can I stage to come in next month, right? Those are great opportunities for AI, reducing administrative friction, lowering burden, making it easier to do the day job. Where AI, I don't think can solve the problem just yet, if at all ever, is you still have a basis of performance to set these benchmarks. You can't manufacture performance, right? So benchmark rates and rate setting and sort of RAF leveling is still going to be a thing.
Yeah.
And it's going to still depend on the actual data and the actual outcomes, and AI is not going to solve for that. And I know that there's a lot of controversy around the RAF changes in Medicare and, some of that rate ambiguity is coming out. And so I think that's just a nature of the beast, right? We have to get more accurate at coding. We have to get more accurate in discipline and actually backing up things we said happen at the patient level. I don't think AI will solve for that. I don't think AI will solve for just the premium pressures that payers are under.
Yeah.
Right? They have to do more with less. Employers are demanding that premiums don't skyrocket. And how do you demonstrate value and still keep your MLR intact and still keep your company running and still attract that account? There's a lot to balance. And I don't think AI is going to solve for that, right? So there are still realities of healthcare that we have to address. Things have to be, the economics have to work. And you can't escape the economics. What you can do with AI is maybe create opportunities to create efficiencies, to reduce burden, to reduce waste. But ultimately, the fundamentals of healthcare economics are not going to be changed by the innovation of the AI, in my opinion.
I'm curious, how does syntax play into all of this?
Yeah. So if you've been tracking what I've been talking about, then clearly we're passionate about value-based care. And one of the areas that was really important for us at Syntax was what is missing? What's the missing gap in trying to get more providers involved in value-based care, right? And from our experience and our vantage point in running these programs, the three biggest areas of failure in value-based care was I'm signing something I don't understand. So the payer is trying to push risk on me, and I understand it. They're trying to push accountability and say, you should be accountable for these members. You're going to quarterback their care, right?
Is it usually a physician signing or is it an organization?
It depends.
Okay.
Truly, it depends. You could have an independent practice that's large enough that could be signing that contract. It could be a large physician group and a physician leader over that large group, right? So it really depends on the structure of the practice. It could be a clinically integrated network, but someone's accountable, right, for that population, and they're signing contracts they don't understand. It's very...
And those legal fees are massive. So then you're adding to the cost of healthcare.
And it's not even from a legal fees perspective, right? Because the contracts hardly involve a lawyer, so to speak. They involve actuaries. They involve analysts. They involve folks who are trying to do back of the envelope math, which is really scary when you're talking about taking on risk and setting reserves, right? So one failure point is not understanding the contract model. The second failure point is you're in negotiations, but it's lopsided information. Imagine we're negotiating to sell a table. I know how much a table costs. I know where the table came from. I know how much it costs to get the wood, to get it together, to get the carpentry. And you're just like, I don't know, I'm here with the table. Right? And so it's lopsided. And so that's also a failure point. And the last one is value-based care is so different economically from the flow of funds than any other reimbursement methodology, right? Because in value-based care, I'm signing up today for something that's going to happen in the future that I have no control over. And I'm making a bet that if I do all these things right, I'm going to get a payment. There's this carrot that's sort of hanging out there for me, right?
And we're talking about, when you create access, there's a negative ROI for quite a while. So can you do that in 6 months? Can you do that in 8 months?
So many of the folks that we work with who are digital health companies, we've actually started to be a bit more prescriptive in how we support that business. But I can't tell you how many startups, we want to get in value-based care. Okay, what outcomes do you have? Oh, we can improve engagement. And is that a good thing? Based on whose lens?
Yes.
Right? And I think the reason why we're different is because we came from payers. And so we really understand the economics of care. And all access is not good access if it's the wrong patient, and it's wasteful. Right?
Thank you for saying that. Mic drop.
And it's sad because unfortunately these metrics are so misaligned with how cost of care actually works. And it doesn't take that much to just have a conversation about what the true metrics that we're looking for matter, right? But oftentimes it's happening after the fact. And we're now in this reconciliation nightmare. We're in this arbitration nightmare. And it's just like, that's wasteful. That's the legal fees we talked about earlier, where we're just wasting money on fees that could have been avoided if you just had a better conversation up front.
Well, and I, one of the projects that I personally worked on was basically unpacking $450 million of overpayments. So from the payer perspective, we're overpaying, right? And from the top 10 causes, the number one, which was over 50% of those overpayments, was due to legal language interpretation. Basically, the payer says, this is what we believe and what we agreed on. The provider says, well, this is how we interpret it. And then it's a complete mess. So having someone sort of own the what is the fee schedule that we agreed on, and not having to have the arbitration happen in the first place.
And that's how you end up with value-based care being labeled as a myth or the hype or like all these people who are value-based care detractors, is because of stories like that. And our mission at Syntax, and our tagline before we were part of Lightbeam Health, and now we got to figure out our new tagline, but it was radical, what was it again? Hold on. A radical approach for practical people. Like, this is practical math. It's not magic, it's math, right? But what happens is we get so excited about the partnership and about the press release and about what the opportunity is that no one stops to say, what are we actually signing here? What are we actually trying to accomplish? Right? And then everybody gets amnesia. and all of a sudden we're fighting.
Yeah.
And that's where the waste happens. And that's where you see folks sort of throw up their hands and say, oh, it doesn't work. No, it works if you know what you're doing and you take the time to be intentional about the model design from the start. You can't fix a poor design downstream.
Oh, I love that.
Can't.
What's one thing you'd love to leave our audience with?
Okay. I think
Okay.
our biggest opportunity, and I'm a child of the 90s, and there was a very popular TV show in the 90s on Real World on MTV. And this tagline was, when people stop being polite and start getting real. And I think in healthcare, and especially in value-based care, we have been polite. We have been talking at the edges and at the fringes of this stuff. And I think we have to get real. And I think we have to have real, transparent conversations about, as a health plan, this is my goal. I need to grow membership, reduce costs, reduce waste. Mr. Provider, I'm going to offer this incentive agreement. And if you do these 5 things to help me reach these goals, you're going to get to share in that.
Yeah.
And the provider has to be honest and say, to do that, I need data.
Yeah.
I need you to be transparent with me. I need to have this exchange, right?
Yeah.
And until we start having those real conversations, we're going to keep playing around the edges and we're not going to see the change we need to see.
So now I'm curious, what do you think about quite a few payers literally dropping members so that they can retain that margin?
Yeah,
I mean,
scary.
where are we at?
Yeah, it's scary. It's hard for me to argue with why, because the economics of that business has not been good.
Yeah.
And I worry about where will people like my dad go, who was in Medicare Advantage and who's had incredible opportunities to have care that he could not afford otherwise.
Yeah.
Right? Because of Part D and Part C. And but I do think it'll hopefully spark a sea change. And we'll have a different conversation about affordability and how we need to be able to have health plans give options that people can afford and that members can, take advantage of. And we've got to get some of these middlemen out the mix that are just rising up costs.
Yeah.
So,
wow. Thank you so much.
Yeah.
This was amazing.
Yeah. I'm so glad. Thank you for the opportunity.